Episode 10, Sports Medicine Case Series. 8 years of chronic fatigue. 41-year-old lawyer with a history of 8 years of chronic fatigue that accumulated at the end of a normal working day. 2 years previously, the patient had the incidental finding of mild anemia. The patient's values from an outside laboratory included a hematocrit of 33%, hemoglobin 11, mean corpuscular volume of 102, a reticulocyte count of 2.3, white blood cell count of 3.1, and platelet count of 133. A bone marrow aspirate was performed at an outside institution described as, quote, cellular with erythroid hyperplasia, stainable iron, and no ringed sideroblasts. The outside interpretation suggested the presence of moderate megaloblastic changes and occasional dysplastic cells. While the interpretation was not definitive, the report raised the possibility of a myelodysplastic syndrome. The patient's past medical history was remarkable for a tubal ligation that was subsequently subjected to reanastomosis. Her medications included as-needed use of ibuprofen and diazepam. She had no known drug allergies. Her diet was described as normal. She had no history of toxin exposure. A review of systems revealed no excessive bleeding, weight loss, or night sweats. She did not smoke or abuse alcohol. Her appetite was normal and she exercised regularly. There is no family history of hematologic disorders. On physical examination, vital signs included a weight of 103 pounds, blood pressure 104/60, pulse 76, and respirations 18. She was anicteric. Her oropharynx showed no exudates. She had small bilateral non-tender mobile submandibular nodes and a small mobile right axillary node on lymphatic exam. The lung and heart sounds were normal. Her abdomen showed no hepatosplenomegaly, and her extremities were normal. She had normal vibratory and two-point discrimination in both lower extremities and no other neurologic abnormalities. Repeat laboratory studies at the time of examination included a hematocrit of 34%, hemoglobin of 11.3, red blood cell count of 3.28, MCV of 102, white blood cell count of 4.3, and platelet count of 190. Reticulocyte count was slightly elevated at 1.9%. The peripheral blood smear showed macrocytic round red blood cells and occasional fragments with no polychromasia or stippling. The white blood cell series was slightly decreased with an occasional hyposegmented neutrophil. The platelets appeared normal. Differential diagnosis: some type of hemolysis, vitamin B12 or folate deficiency, use of medications interfering with DNA synthesis such as antifolates, nucleosides, and hydroxyurea. Outside conditions which may have influenced macrocytosis. This would include alcohol overuse and liver disease. And then bone marrow failure states such as aplastic anemia. That differential comes entirely from the author. With a slightly elevated reticulocyte count, hemolysis was suspected. A haptoglobin level was measured at 29, with the normal range being 60 to 270. The decrease in haptoglobin level suggests a hemolytic process. Because concomitant iron deficiency, which commonly occurs in menstruating women, could cause an inappropriate low hematopoietic response, iron studies were performed. The iron studies revealed the normal serum iron level and iron saturation. The ferritin level was 62, with the normal range being 10 to 110. A direct Combs test was also negative, as was bone marrow karyotype. These findings were not consistent with a myelodysplastic syndrome, but that could not entirely be excluded. This led to further evaluation and an explanation for potential hemolytic anemia. This was confounded by the observation of reduced iron stores. Because of the reduction in iron stores, the patient received iron supplementation as a therapeutic trial. This trial did not improve her hemoglobin level, which remained at 11.5 after 2 months of full iron therapy delivered orally. The urinalysis and urine hemosiderin values were negative on follow-up. The diagnosis was ultimately made by measuring the red blood cell mass and plasma volume using radio-labeled tracers, which revealed a normal red blood cell mass despite low hemoglobin and hematocrit values. A careful history of the patient revealed that her usual exercise consisted of an 8-kilometer run every other day. It was then hypothesized that the patient's presentation was most consistent with the uncommon diagnosis of runner's anemia. I'd like to recognize the author, Dr. Dang, Johns Hopkins University. This was published in JAMA in 2001. Really nice article. I'm Scott Hall, a primary care sports medicine physician at the University of Utah. I'm studying for my sports medicine recertification exam in 2026. And I'm reviewing relevant case studies, and I hope you'll join me on the journey and learn something along the way. This podcast is for educational purposes only. To confirm the suspected diagnosis, the patient was advised to stop running for 4 weeks. When her hematocrit value was reassessed, it had risen from 34% to 38%. Since this change was of no physiologic or symptomatic consequences, she resumed running with the comfort of a definitive diagnosis for her persistent pseudoanemia. She still had baseline chronic fatigue that is unlikely due to her hematologic status, according to the author. A couple of key takeaways from me. It is notable that the MCV increased as a function of running mileage. The very mild reticulocyte count elevation, however, does not appear to fully explain the increase in MCV. Therefore, it is hypothesized that older, smaller red blood cells are more susceptible to Footstrike hemolysis, which spares younger and larger red blood cells. In addition to hemolysis from Footstrikes, GI bleeding, which is thought to result from ischemia during long-distance running, has been documented in up to 20% of runners. Clinical pearl number 2. Runner's anemia is largely due to plasma volume expansion with elements of hemolysis, hemoglobinuria, and in long-distance runners, GI blood loss. Clinical pearl number 3. Footstrike hemolysis is a mechanical destruction of red blood cells caused by repetitive impact forces when the feet strike the ground during running. It contributes to runner's anemia by causing intravascular hemolysis that, combined with plasma volume expansion, produces dilutional anemia. The mechanism involves forceful striking of the feet against the ground, which physically ruptures red blood cells as they pass through capillaries in the foot sole during impact. Studies demonstrate that Footstrike is the major contributor to hemolysis during running. Plasma-free hemoglobin increases 4-fold more after running compared to cycling at equivalent oxygen uptake. I'm going to skip that. Practice questions. Question 1. A 28-year-old female distance runner presents with a hemoglobin of 11.2 and a hematocrit of 34%. She runs 50 kilometers per week on pavement and reports no symptoms. Which laboratory finding would best distinguish true iron deficiency anemia from runner's anemia? A. Elevated reticulocyte count. B. Normal red blood cell mass with expanded plasma volume on radio-labeled testing. C. Decreased serum haptoglobin. D. Elevated MCV. The answer is runner's anemia is characterized by normal red blood cell mass with expanded plasma volume, creating a dilutional anemia rather than true anemia. Question 2. A study compares free plasma hemoglobin levels after 1 hour of running versus 1 hour of cycling at equivalent VO2 max. This VO2 max was at 75%. What magnitude of difference in hemolysis would be expected between the two activities? So cycling versus running. Answer A, no significant difference. B, 2-fold greater after running. C, 4-fold greater after running. D, 10-fold greater after running. Answer C. Plasma hemoglobin increases 4-fold more after running compared to cycling at equivalent oxygen uptake, confirming that mechanical trauma from the foot impact is the major contributor to hemolysis. Question 3. Which of the following mechanism best explains why mean corpuscular volume increases with running mileage in athletes experiencing Footstrike hemolysis? A. Increased reticulocyte production. B. Vitamin B12 deficiency from increased metabolic demands. C. Preferential destruction of older, smaller red blood cells. D. Mechanical enlargement of red blood cells. Answer is C. Footstrike hemolysis preferentially destroys older, smaller red blood cells while sparing younger, larger cells, leading to an increased MCV that cannot fully be explained by mild reticulocytosis alone. Question 4. According to the American College of Sports Medicine, iron requirements for endurance athletes, particularly distance runners, are increased by approximately what percentage compared to non-athletes? A, 30%, B, 50%, C, 70%, or D, 100%? The answer is C. Iron requirements for endurance athletes, especially distance runners, are increased by approximately 70%. Last question. A triathlete asked whether switching from rear foot to forefoot striking would reduce his susceptibility to Footstrike hemolysis. Based on current evidence, what is the most appropriate response? A. Forefoot striking significantly reduces hemolysis. B. Rear foot striking significantly reduces hemolysis. C. Neither striking pattern appears to significantly reduce susceptibility to Footstrike hemolysis. D. Only midfoot striking reduces hemolysis. The answer, C. Studies comparing forefoot and rearfoot runners show similar haptoglobin responses, indicating that neither striking pattern significantly reduces susceptibility to Footstrike hemolysis. Thank you.